So my name is Iwuh. I'm a doctor. I'm an obstetrician, and I'm the lead obstetrician gynecologist at Area 25 Health Facility, which is in Lilongwe. I work for Baylor College of Medicine, which is a public-private partnership with the Ministry of Health of Malawi. I'd like to see that we're able to help the efforts towards reducing both maternal and newborn morbidity and mortality, as well as see that these women that actually we have been able to help, we can help them prevent them getting cervical cancer and possibly treat if they do get cervical cancer. The message is to just emphasize that one of the better ways or one of the potential solutions to addressing the multiple problems that are existing in a certain low-income setting like Malawi is to establish a system of sustainable public-private partnership, which will entail sustainability, entail leadership, exemplary leadership, where you have models who are there and who work hard, who are passionate, who actually will motivate others to be in the system and work hard. And I think I must say I'm thankful that there is this relationship between Scottish Malawi Partnership and Malawi Scottish Partnership, because then it integrates the needs from Malawi, and also that those needs are actually articulated to the Scottish partners. But I think we all need to be cognizant of the fact that long term, for us to have long-term sustainability, we look at the main needs of the people we are intending to serve. So I'm going to go to tell you a bit more about my vision, our vision. So I work for Baylor College of Medicine in a public-private partnership at Area 25 with the Ministry of Health of Malawi. So that's our labor unit. So I've given you a little bit of flavor about Malawi. The maternal mortality is very increased, it's very high. And we all know the causes, and most of those are very avoidable. The low-hanging fruit, as described by my boss, Dr. Jeff Wilkinson, meaning that it is something that we do not need a lot of resources to actually address. We need people who are passionate and who are available. We all know about the 3 delays, and at Area 25, our vision is to address those 3 delays in terms of healthcare provision. We're trying to make sure that these women get to the hospital, they get access. When they get to the hospital, they can be timeously seen, and even after timeously seen, any possible complications can be prevented. We all know also that the stillbirth rate in Malawi is also very high, and in the same vein, we're trying to reduce maternal mortality and morbidity. We also aim to reduce neonatal stillbirth rate and neonatal morbidity. We all have all those interesting indicators, as you can see, antenatal coverage and all of that. So we see that a good number of women are able to get to the health facilities as we speak. But the problem is, when they get to the hospital, do they go home with live babies? And do they go home intact and happy and healthy? Because a woman comes into the hospital with a live baby, she should go home healthy with a healthy baby. That's our vision, one of our main visions. I'm not going to tell you much about Lilongwe because most of you already know about Lilongwe. But it's a very densely populated city in the country. There are only 2 places in the government facilities that provide cesarean section services. Boila, as you know, is one, and Kamuzu Central Hospital is the other. You can imagine with the expansion of the population and with everything going on, there is need for more. So, before I tell you about that, which I'm sure a lot of people in the group who work with fistula patients. So, my boss, my organization, Baylor College of Medicine, went into a corporate arrangement with the Ministry of Health in order to address these 3 levels of delay. And they thought that if we got into this partnership, it might be a potential solution addressing this problem. We might be able to provide timely cesarean sections to the women that need it. We might be able to monitor the women when they are in labor. We might be able to provide timely referral as needed. So going to obstetric fistula, I'm very thankful to the fact that we have someone like Anglo who is very much invested in Malawi in helping the whole, call it a war against fistula, because she's providing a lot of support. But Baylor College of Medicine also is involved with that, providing the doctors and the surgeons. As we know, the figures there speak for themselves. And we still have a lot more women who are suffering from obstetric fistula. They get stigmatized in the community. They get almost ostracized, and no one wants to go through that. We have a recent paper which talks about depression among women who have actually experienced obstetric fistula. So where do we come in? We want to make sure that if we provide timely cesarean section, it is safe and it is good enough to prevent more fistulas. So we think most fistulas happen from obstructed labor, but these days we are seeing more fistulas from iatrogenic practices. So they do unindicated cesarean sections, probably because they're not properly trained, and that also will lead to obstetric fistulas. So what do we have at Area 25 is a public-private partnership. It's an urban health center. It's quite busy. I'll show you a picture of my typical day at work. We have about 5 health facilities that it caters for. We have a lot of deliveries per day, 20-25, and with the current project coming up, we are looking at doubling of that number because people gravitate towards where there is good care. So we have about 20-30% of those patients we see referred for cesarean sections. Unfortunately, not all of them get the timely cesarean sections because when they get to the referral center, there is congestion, there is a lot of delay, and what happens at the end of the day, there is compromised care to the patient and her baby. I have sent so many patients for cesarean sections, and I get a feedback that baby didn't make it. It's not the best thing to hear, especially when you have cared for this patient throughout antenatal time. And we have unacceptable patient outcomes. The problem is that a lot of times this is blamed on the junior doctor or the junior clinician who is least skilled, but who is put in the deep end to take care of all of this, while you have very few specialists who are available to train and to support these junior doctors. What is our model at Area 25? It's a bit all squashed, but we are looking at a triangle of success. For us to be successful, we are hoping that we can build relationships. We can actually go through a process. So going through a process of being accountable, communicate better with our colleagues, build relationship. I'm glad that I'm here today telling people about our work, and our results will be to achieve high obstetric and neonatal care, develop a center of excellence at Area 25, and to prevent more obstetric fistulas, eradicate cervical cancer, and empower women. That's my typical day at work. And I'm glad that I'm able to reach out to as many people as I can. I have good support. We have a lot of clinicians who work with us. So it's not one-man team, so it's a collective effort. So what do we do at Area 25? We have both clinical and non-clinical activities going on. We have a holistic approach in where we integrate nature. We have a garden, and we also integrate that with health. I'll explain a bit more about our garden project. We have an active OB-GYN clinic every Monday. We see about 100 to 120 clients per day in the antenatal clinic. We have a more focused, directed labor ward supervision and training. We run family planning clinics. We have a waiting home, and this waiting home, the idea is to improve access, and this is to actually address the primary delay. We have an ambulance which is currently bridging the gap, so we have quick referral to the central hospital, and we are also doing cervical cancer screening. We're doing VIAs. We intend to start helping, so we want to get involved with the screen and treat aspect of the whole cervical cancer screening, which seems to be a new thing, a new project my colleagues are going into. We hope to achieve a center where there is a lot of potential for collaboration, both locally and internationally. And the hope is to make Lilongwe to have a Lilongwe district hospital so that we can be able to decongest the central hospital. What about maternal neonatal health issues initiatives? So with this collaboration, Baylor College of Medicine is building 4 operating rooms, and this will now address some of the delays I was alluding to. We hope that we'll be able to perform timely cesarean sections, prevent both maternal and neonatal morbidities. And the Baylor has been able to employ enough staff. So in the public-private partnership, we have about 35% Baylor staff and then 75% Ministry of Health staff. We are creating a very cohesive team that has one vision, and the vision is to reduce both maternal and neonatal complications. We have so much investment already in the maternity waiting home and the garden project, which I will show you in a moment. And then we also currently, actually next month, we're having a sanitation project at the facility to improve the whole outlook of the facility. So what are our projected benefits? What do we intend to achieve? So I already alluded to the fact that we intend to decongest the central hospital. We intend to improve both maternal and neonatal health. We intend to allow easy transfer of skills. So if we decongest the central hospital, they have more time to train the younger doctors to be able to provide better care. We intend to improve individual staff happiness, because a lot of staff go through work every day actually feeling very unhappy and sad. We do not want that kind of environment. And long term, we want to achieve a center where people are happy. We want to achieve a functional unit. And at the end of the day, this might help us towards the whole SDGs for 2030. What's our bigger picture? We want to be a model. We want to be able to demonstrate that with a public-private partnership, we may be able to provide a solution to the current status of things in Malawi. We hope to be a training institution for basic cesarean section and a lot more, but I've alluded to the bigger ones. So, sorry, I don't know if I have much time, but I'll just tell you a little bit about the integrated land use design. So we have a garden that we intend to grow it to be a project that actually empowers women. So in our maternity waiting home, we have about 30 or 40 patients at one time. These patients are seen daily by clinicians and nurses. These patients are trained. They're given lectures on family planning, breastfeeding, and nutrition. And through the garden, we train them to know how to combine iron-rich foods. And this builds up the hemoglobin count, and that obviates the need for transfusion when they go into labor. As we know, blood transfusion is not easily accessible in Malawi and the rest of the country. So those are the things. So we intend to do tree planting activities. So for every baby that is born, we will send mom with a tree. She takes that to the community and plants it. And that will be part of empowering them. While they're with us, we train them on how to empower other women when they join the community. So I call it the smaller big things. And our hope is in the next couple of years, we have a system of very empowered women who know what foods to combine, who know how to teach other women, and long term, we have better outcomes for both the babies and the mothers. The lady in the picture is the one spearheading our garden project.